Hello and welcome to safeultrasound.org. My name is Evelyn Luce, and in this upcoming brief presentation I will guide you through the performance of ultrasound-guided axillary brachial plexus anesthesia. The brachial plexus arises from the C5 to T1 nerve roots and comes to lie between the extension of the prevertebral fascia and the muscular fascia surrounding the anterior and middle scalene muscles. This fascia is continuous with the fascia that encompasses the cervical plexus as well. From the interscalene space, the roots converge to form three distinct trunks: superior, middle, and inferior trunk. The trunks will bifurcate into anterior and posterior divisions at the supraclavicular level. Those divisions subsequently form three cords that are named for their location relative to the axillary artery, medial, posterior, and lateral cord at the infraclavicular level. Finally, those three cords give rise to the terminal branches starting from the upper border of the clavicle at the axillary level. For optimal positioning, the arm is abducted, flexed, and externally rotated. The probe is positioned in the transverse plane to obtain a cross-sectional view of the vessels and nerves. Please note that in this particular view, the marked side of the ultrasound transducer is pointing up. In this schematic view, we have superior to the left and inferior to the right. Please also pay attention to the position of the individual muscles. The biceps muscle most superior, immediately posterior to that, the coracobrachial muscle, and then inferior and posterior, the large body of the triceps muscle. You will also see the axillary artery superior and immediately inferior to that, the axillary vein. There is significant variation when it comes to the individual position of the nerves around the artery, but most commonly the median nerve is positioned superior, the ulnar nerve inferior, and the radial nerve posterior. Frequently, you will also see the musculocutaneous nerve. Needle placement will be determined entirely by the anatomy of each individual patient. It can occur from inferior, anterior, or superior, as long as contact with the nerve itself is strictly avoided. Axillary brachial plexus block can be performed in an in-plane or out-of-plane approach. Usually, your needle position is assessed by local tissue movement and the spread of local anesthetic. In order to avoid undesired contact with any nerves or vessels, we advance the needle slowly. We frequently inject very small amounts of local anesthetic, a technique which is often referred to as hydrodissection or also hydrolocalization. Once we appear to be in the correct fascial plane, we will inject the entire amount of local anesthetic surrounding the nerves without ever contacting them directly. This is a JPEG image of the schematic you just saw. Subsequently, we still have the same orientation, superior to the left and inferior to the right. In the middle, you have the large body of the biceps muscle. You see the axillary artery in the middle of the screen. Immediately inferior and a little bit anterior to that, the axillary vein. My first arrow is pointing towards a cluster of hypoechoic nodule that represent the median nerve. This would be the ulnar nerve, a little bit more inferior and posterior to the artery, a little less visible, the radial nerve. You can also always see the large body of the triceps muscle. This first clip we are showing you has maintained the same orientation, superior to the left, inferior to the right. You can see the axillary artery in the middle of the screen. And this is going to be an out-of-plane approach, so you will see local tissue movement and spread of local anesthetic. The needle is advancing in an out-of-plane approach from immediately inferior. And as soon as you are starting to have increasing spread of local anesthetic, very soon you are able to identify the hypoechoic nodules of a nerve. This nerve that's pointed out by the yellow arrow represents the ulnar nerve most inferior. Now, as we are in the correct fascial plane, and as the spread of local anesthetic continues to increase, you're seeing a second nerve become apparent, and that's the median nerve at 11 o'clock, pointed out by my second arrow. With increasing spread of local anesthetic, you have the artery completely surrounded and have a wonderful block. This is a different patient. We have maintained the same orientation, superior to the left, inferior to the right. And as this is an in-plane approach, you will see the entire length of the needle. The needle is approaching through the belly of the biceps muscle. And again, with increasing spread of local anesthetic, after a short period, you can start seeing the hypoechoic fascicles of the nerve that is clearly becoming more demarcated by the surrounding local anesthetic here, pointed out by my yellow arrow. This is the median nerve. The operator here is proceeding very slowly, very deliberately. That's definitely the beauty of ultrasound, that you have the ability to watch the appropriate spread and to adjust your needle position accordingly. Now we are making our way inferiorly here. We are carefully avoiding the vessel. We are pushing it down with a needle. And again, we are going very slowly. We are continuing to fill up that space with local anesthetic in order to get a complete block. The patient has no discomfort with it. He already feels a lot of numbness while we are carefully and slowly injecting. And you will soon see another nerve appear as spread of local anesthetic increases. Here you can see this is the ulnar nerve that was just surrounded by local anesthetic and is literally pushed up, is pushed anterior, completely surrounded by local anesthetic. This is again a different patient. We have maintained the same orientation, superior to the left and inferior to the right. This clip demonstrates very nicely the fact that there are many patients with multiple vessels and varying anatomy. We're starting this clip, and there are at least 2 arteries. We made those visible with color flow. We're trying to figure out how many veins there are. There are at least 3. We often compress the tissues in order to see how collapsible the veins are. You can see that here. And I believe using ultrasound in this patient not only helped us to identify the correct artery that had the nerves grouped around it, which is this artery, but it clearly helped us to avoid undesired vascular or nerval puncture. I hope you enjoyed this brief presentation. We are looking forward to having you visit our website again. Thank you very much.